Good afternoon. I'd like to call the November 9th, 2015 Human Services Committee meeting to order. First on our board docs, we have the approval of the agenda. We have motion and support. Are there any corrections, additions, deletions to the agenda as printed? Seeing none, we will move forward with this agenda. Public comment? Is there anyone that would like to address the Human Services Committee? Seeing none, we'll move on to committee items. We have the meeting minutes of October 12th, 2015. Motion made and supported. Any corrections? Additions, deletions? Seeing none, all in favor vote aye. Opposed? Minutes are accepted. Lifeway's monthly report. Mary Beth?
Good afternoon, Commissioners.
Afternoon.
All right, so this month in your packet you'll find the report, so I will highlight some points on the report. First one is related to local match. As you know, currently our efforts as an organization is to work through the Legislative Committee, through our association, to change Section 428. That would no longer require the Medicaid match appropriation of the CMH utilizing local dollars. So we're currently trying to continue that advocacy through our association. So that was under advisement from our legal counsel related to the fact that the state did not uphold our request to reinstate our general fund dollars that they had reduced. So we will continue to do that, and I do know that Commissioner Rice is also having discussions with MAC because this does have greater impact than just the community mental health system, but this also impacts counties. So it would be important if we could also get Michigan Association of Counties to support the endeavor related to changing Section 428. But I'll continue to keep you appraised. We meet as a legislative subcommittee of the board next week of the association, and we'll continue to have that fight about local match, but just wanted to let you know where we're at. The other thing that I kind of wanted to give you an update on, and it's just in the early stages of discussion, myself and United Way and DHS, as well as Public Health Department, has been having some discussions about a financial single-stop access. And why that's important is we know as we look at the future of healthcare and the importance of trying to reduce administrative costs and redundancy in the system for individuals accessing services, that if there's an ability for us to look at a model that is a single source entry point, whether the model is an actual location or the utilization of a standardized access form across the system, that would benefit our communities. So we are in the process of having those discussions and looking at different models that are out there. And Detroit Wayne is one of the areas in which they have implemented a financial single-stop access point. And so I just wanted to kind of keep you appraised that we're having those discussions. We also are recommending that the Financial Stability Committee of the HIO also evaluated. It feels like it's a good fit with the Jackson Financial Stability component of the HIO, but wanted you to know that that effort is underway. And again, it's just in the initial planning and evaluating, and a commitment that we do understand that that is important if we could get to that as a community. The other thing that's important that we're really trying to look at and collaborate as a community is around county guardianship. So currently there's a significant challenge related to sustainable financing for county guardianship services. So all the parties that are involved, both Allegiance, the family independent, not Independence Agency, it's eluding me now, but Family Services and Children Aid, who currently oversees the guardianship program, along with Lifeways, is kind of talking about what is the current state, what's the desired future state, and how can we look at collaboratively sustaining that program, because there is a need within our community. There is a correlation with a work group that I participate on right now at the state level that's also looking at some guardianship issues. So I'll continue to keep you appraised as we move down that road, but right now we do know that it's a need. We do know that there's a challenge with financial stability of the guardianship program because there isn't anybody that has funding coming in to sustain it. Even Lifeways is providing some support for that, but that comes out of our GF and local. There's not any funding that comes from Medicaid for us to continue to support that endeavor. But just wanted you to be aware of that. The other thing that's occurred in September, actually, the end of September, was related to mental health first aid training for law enforcement. We provided that training and had a significantly good turnout from law enforcement and first responders in Jackson. And we actually had 2 individuals who were identified as being potentially interested, who are law enforcement individuals, to be train the trainers, which would be huge, because it really is important when you look at mental health first aid that it is individuals that actually have the impact to make change and advance that training, especially around law enforcement. The feedback that we got from those that attended was very well. We will be looking at future trainings related to mental health first aid for law enforcement as well in the future, but I just wanted you to keep you appraised of that effort. That we've been trying to provide that for law enforcement for a very long time, so the fact that we were able to have that and have such a turnout was really well. The other packet that's in here in regards to some things that are happening at a regional level that impacts Lifeways. First, we did have a change in the CEO, so Nancy Miller has officially retired at the end of October. Joe Sedlock is now the new Mid-State Director for the regional entity, and that went into effect November 1st. We did have changes in our Medicaid rates. The last time I spoke with you, we did not yet have the rates, and there was a potential that we would have to go back to our board and do an amended budget if we were to experience a reduction, and that was not the case. So our budget, as it was approved by our board, remains in effect, so that was a good thing. The region actually saw a slight increase in the Medicaid that they initially had projected. The other thing that's important is related to the PA2 funding. So beginning in October, prior to that, there were 3 coordinating agencies within our region. So for Jackson and Hillsdale County, it was CEI. You might have heard of it, Central Eaton Ingham Community Mental Health. They provided the coordinating agency function related to overseeing through the coalitions, the Substance Abuse Coalition, the use of PA2 dollars. When they regionalized that and brought it all under Mid-State beginning October 1st, one of the things that they clearly saw was the discrepancy across the 21 counties related to how PA2 dollars are requested and authorized and used, and what was available for counties. So right now, Mid-State is looking at coming up with standardized criteria for how people would request, how counties would request the use of PA2 dollars, what would be the formal approval process. And then the other outstanding thing that's still out there is that 25 proposals are out there as a region related to the use of those dollars. Jackson Lifeways has a proposal out there as well, and that's related to the expanding of detox services. And we also wanted to create an engagement center, and I've talked about that here before, about what a benefit that would be to our communities, because it would keep people out of the ER and reducing costs on inpatient when we could have an engagement center that could provide that service. So they're in the process of reviewing and approving those proposals. I'll continue to keep people appraised of that because it does have an impact here locally, obviously. I was hoping by today, at least I was hoping actually by last week, I would have heard where Mid-State was related to the approvals. I received an email this morning from Joe, because I inquired, okay, where is that? You had said this several weeks ago, I still have not heard anything. But they will be announcing formally soon what those approvals are. So still don't know, but I'm hopeful that Jackson's will be approved. The other thing that we continue to struggle with as a region that's in your packet is a discussion about inpatient capacity. So there was a committee that was held at the state. There's a thing called a certificate of need, that hospitals have to have so many openings. When they open an inpatient unit, a hospital is required to maintain a certain percent of those beds for individuals that the community mental health serves. We've been challenged as a region and locally related to being able to place people. A lot of times, some of the denials are that individuals don't meet the milieu of the hospital. They don't want to take some of our most challenging patients that we serve, and there really is no other place for them to go. So at times, we have individuals in our ER up to 5 days or longer while we contact every single psychiatric unit in the state to try to find placement. What we participated in the Certificate of Need Committee, in which they allowed CMHs and other organizations to come and testify about the challenges related to capacity and finding placements for people. One of the outcomes of that committee is that they are going to be recommending that a central registry be developed where a CMH would be able to go to the central registry and be able to see all of the different psychiatric inpatient units in the state and know how many beds they had available for the certificate of need. So we wouldn't be spending a lot of time calling places who didn't have an opening. You know, you could narrow a lot, you could save administratively a significant amount of time on staff. And hopefully be able to more quickly get somebody into a location where they did have an opening. So we're continuing to look at that capacity problem, but that is something that was committed from the Certificate of Need Committee about making that change to improve access. So that's important. The other thing that was recently announced, and it's included in your packet in case you're wanting to know who the health plans were that were selected for our region, that does have it broken out by counties within our 21 county area. So you'll see Jackson listed there in the 5 health plans that were selected. So that is it for my report, unless there are questions of the board.
Commissioner Rice?
Mary Beth, I'm aware of this, and you touched on it. I just want to clarify. When you talk about people needing to be placed psychiatric care, as well as therapeutic, of course, but you're saying there's an issue that's occurring with Allegiance as far as who they take or don't take? I mean, so they might have an open bed, so the term that they use in hockey would be they're cherry picking?
You could call it that, but their term is that it doesn't fit milieu.
It doesn't fit their dollars. All right, thank you.
Yep.
Thank you for that insight. What other comments or questions might you have for Mary Beth? All right, seeing none, thank you for that report.
All right, thank you.
Thank you. On the agenda next, we have the Health Department. We are looking at authorizing a contract agreement with MDEQ for the period of 2015 through 16. Richard.
Good afternoon, Commissioners. Thank you. It is our standard agreement that comes up every year with MDEQ. The only really significant change in it, and it's not really significant, is in the amount of dollars, if you will, we receive in 15-16. Slight increase of $1,478 from the 2014-15 amount. Otherwise, it's pretty much the same. And we've continued to provide services even though the contract expired September 30th. We pretty much do that every year. So I'm recommending approval.
What comments or questions might you have for Richard? We have a motion and support to move this contract to the full board. All in favor, say aye. Opposed? This will move to the full board.
Thank you.
That was easy enough. Now on to a Health Department monthly report.
My report's in your packet. There weren't any other attachments this month, and glad to be able to keep the packet as small as possible. I know it gets kind of large sometimes. We had a little bit of activity in October in emergency preparedness. It was mostly kind of internal focused with employee call down being completed the evening of October 14th. We do these about every quarter, and they go quite well. In this particular one, we actually utilized the call down to have staff bring in their N95 protective masks so we could exchange them. They actually do have an expiration and a shelf life on them. It's about 5 years, so we were able to do that and keep employees safe at work. We also have been, as you probably have heard me discuss before, organized floor wardens and door monitors in the Human Services building. It kind of went by the wayside a number of years ago when facilities needed to downsize, but we kind of restructured that now and took the lead in the building to do that. So we're very pleased with where we're at with that, with all the partners in the building, and we are planning a fire evacuation or a fire drill yet this fall. I want to share some information with you too on medical director contingency planning. Calhoun County actually suddenly lost their medical director, Dr. Greg Harrington, early October, late September. And I don't think that we necessarily thought about the potential impact of losing a medical director in a health department, particularly if it's the only one that you have. In his particular case, it was an accident involving a vehicle, and I think and a bicycle. Very sad that this occurred, but what the effect of it in Calhoun County was basically all their medical standing orders became null and void immediately. So they weren't even actually able to bill for services that were coming through their client services in their clinics. They actually had to shut down a few clinics for a few days until they could figure out how to get another temporary medical director in place. And so we kind of talked about that in the October Public Health Conference with the rest of the health officers and came to the conclusion, okay, we have Dr. Laurenchuk here in Jackson County, and he has signed all of our medical standing orders. But we also have co-medical director Amy Schultz, and she has not signed those medical orders. So it just made sense to us, we need to have co-signing take place. And so we're setting that up. She has to renew her pharmacy and DEA license, but she's in the process of doing that. So that was actually a good takeaway, if you will, I guess, from that experience, unfortunate as it was in Calhoun County, but it kind of raised our eyes a little bit and opened them up. A number of staff attended the Premier Public Health Conference this year, and I did do a presentation on how we're doing here in Jackson County with shared health officer services, and kind of describe that as health integration at the intersection of public health and health system. And I think we're doing very well and making progress. Strategic plan development, unfortunately, you may recall I talked about this in previous monthly reports that we really wanted to jumpstart the process of preparing for national accreditation by getting a strategic plan done. We had applied for $15,000 through the National Association of City and County Health Officials. Unfortunately, we were not selected for funding. They had probably 200 applications, and they only funded about 10 or 12 health departments. So the competition was pretty fierce. However, we're looking at other resources we may have available either within the budget or from other organizations within the community that might be willing to fund it. We probably need about $7,000 to $8,000 to make this work. And so we're not giving up on it. We'll continue to find a way to get it done. The Health Services Access Coalition is moving forward. We had a good meeting on October 29th. I indicated that in my report. And it actually is beginning to kind of gel now. We're going to be developing policies and procedures that kind of define how we approach access issues in the community, and being very mindful of the fact that we also have the Human Services Coordinating Alliance and how they fit into the picture as well. So we'll be moving that forward through the end of the year. Sustainability Financing Group. I know Mary Beth talked about the Single Stop Prosperity Center. This is another one that kind of has some financial aspects to it. Dr. Amy Schultz and the Jackson Health Network and myself have all been working together, if you will, to figure out how to make the transition to the next payment model for healthcare services on a nationwide, a state, a local basis, if you will. It is going to happen. It's happening probably faster than what we anticipated. There are some states that have already moved to, I guess, what you might call a per member per month capitation rate. And I'll use the example of hospitals in Maryland. Over an 18-month period, 10 hospitals in Maryland participated in a per member per month capitated inpatient rate. They saved $100 million after 18 months. And now the entire state of Maryland and all the hospitals there are in a per patient, per member per month inpatient rate for all the care that an individual might need. So it's very innovative, very, very progressive example in Maryland. I think the particular advantage in Maryland was that the state of Maryland actually set the inpatient reimbursement rates as a state agency. So there wasn't all this variability and variation across the board, which makes it very difficult to calculate what an appropriate rate should be. But anyway, that's related to this particular item, and there is going to be this shift to risk-based contracting, both at the provider and the hospital level. And some redesign of benefit plans will probably be necessary, and in order to really improve population health, we're going to need the assistance and participation and buy-in, if you will, from employers in the community as well, who provide probably 60 to 70% of the access for health insurance. So a next meeting is being scheduled for that, and I volunteered to sit on that particular group. I did participate in the Financial Stability Vision Retreat. It was held on October 20th. It was a day-long event, and I think it was very useful for all of us to get together in that kind of retreat. I was there along with many of our other community partners that are looking at financial stability. We had, under Personal and Professional Health Services, we had a very successful HIV test quality assurance site visit on October 12th. We did very well with that. Had no deficiencies at all. Just 2 procedural recommendations were provided, and staff did a great job. Influenza survey analysis report. The only thing I guess I would update there is that we are scheduled to be at the Wesley Street Jail location on November 19th for a flu shot clinic right there with the Sheriff's Department.
So for clarification, that's for the employees?
Yes, county employees.
And is it optional or mandatory?
It's optional.
Thank you.
Would you like to talk about mandatory? Yep. Okay. Because you know where I'm at. We had our first meeting, organizational meeting of the Immunization Action Coalition on October 21st. It went very well. We had good participation, and we'll be finalizing the purpose, goals, strategies, and objectives of that particular coalition along with the partnership agreement, and it's moving forward in the community. An update on the Tobacco 21 resolution. On November 18th, the resolution will be going to the Hospital Board of Trustees, and tomorrow evening it will go to the Jackson Health Network Board of Directors. And I'm pretty confident that they'll support that policy advocacy effort to increase and encourage the state to increase the age of legal purchase of tobacco to age 21. The Teen Pregnancy Prevention Initiative, there was a very nice, wonderfully done presentation on Thursday last week, November 5th, from 6 to 8 p.m. at the Michigan Theater. I'm not sure if anybody here was able to attend that, but it was very well done and very impactful and very interesting to listen to the teens that have been impacted by teen pregnancy early in their lives, how they have adapted, how they have come out the other side. And I think it was quite inspiring at the end to hear them talk about the fact that they recognized that early on they had to give up many of their dreams and hopes and aspirations, including going to college, getting scholarships, participating in major sports teams at university level, etc. But at the same time, I think they've recognized that this, although teen pregnancy does happen and they end up mothers and fathers necessarily, that doesn't mean they have to give up their dreams and their hopes. And they all, I think, everybody that I heard on the panel indicated their strong intention to continue to pursue them. It just may take them longer to get there. So that was very, very nice to hear. Under environmental health, there's an update there on the Missioner Plating Facility investigation and cleanup. It is proceeding fine as far as we know. No additional meetings are actually scheduled at this point in time, but incident action planning continues with first responders, and we're involved with that with the fire department, police department, and emergency management. So nothing else happening there. I did include information here on the Food Protection Hearing Board that was held in late September, and we did have a facility that we've been working with for 15 months who was really struggling to meet the food code requirements under the law, and we had been working with them very diligently to try to clean up and correct all the deficiencies present. We were not successful as of 15 months, and we decided, well, the third step of our enforcement process is the Food Protection Hearing Board. Commissioner Rice and Commissioner Polachek participated with me in that, and we did find that we needed to suspend the license for 45 days. Now, the particular operator is able to open sooner than that if he gets everything fixed and corrected to our satisfaction. Otherwise, if we reach the point of 45 days and we're still in the same place, we will be revoking his license. So that is an end point that would be reached, if you will, with that particular facility in the community. I think that's pretty much everything I wanted to share today, and I'd be happy to answer any questions anybody may have.
Are there any questions or comments for Richard on the monthly report? All right, seeing none, we will move on to the 2014 annual report. It is presented in your board docs. I believe, in addition, the board doc states comment and presentation. However, I believe we need to accept that annual report as well. If someone from the administrator's office would clarify that. Richard, are there highlights in which the annual report in which you would like to address?
Yes, I did prepare a short slide presentation just identifying some of the particular highlights I thought might be of interest to you. Obviously, feel free to read the entire report at your discretion and leisure, and any other questions you might have in it, I'd be happy to answer. It has been a very busy year, and there is a new section in the report that hasn't been in there before, but they're organized, sections are organized, client testimonials, public health and healthcare integration, which is new, environmental health, personal and preventive health services, health education promotion, and emergency preparedness. And also, one update we did for 2014 was we actually enhanced the descriptions of each one of the divisions in the report. So there's more information about what their purpose really is and what they're all about. So we included that in there. Client testimonials are always fascinating. We have one here for the Maternal Infant Health Program. In that particular program, we served 376 women and children in 2014, and the client testimonial is as follows. As a single young mother, the Maternal Infant Health Program has been the most helpful resource in raising my daughter. My social worker has gone above and beyond for me more times than I can count, and is a blessing, and this program has given me the support I can't find anywhere else. Thank you so much. We get many of these kinds of comments from parents in the community that we serve. Car seat program, 796 services, and that's an array of services, but it's both providing car seat safety seats to low-income families that are actually purchased through the Office of Highway Safety at the state level, but also we continue to have the ability to rent car seats for a short period of time. We do educational sessions at the health department for any parent who might need it, and we participate in lots of car seat safety events with the Michigan State Police and Allegiance Health, oftentimes down in the Green Market area. This particular lady indicated to us that she was so grateful for this program. We're foster parents to 2 children, and the help, knowledge, and information we received was invaluable. It was so great to get appropriate car seats for the kids when they were ready to transition to the next stage. The car seat technician was very knowledgeable, gave us a lot of important information. I walked in very unsure of this transition and walked out confident in my ability to install the new car seats. These things are not easy to install. On average, about 80% or perhaps 85% of car seats in Jackson County, when we are reviewing them, are installed incorrectly. There's a lot involved in getting them installed correctly. And so I think it's a very valuable service in our community, and we're really happy to be able to provide it.
Richard, you know, and I've heard that number, and I don't doubt that number. I guess my question is, what are we doing about it? Because to me, it should not be rocket science to install car seats. I mean, is there a national movement or organization addressing this with the automobile industry and the car seat industry? This should not be rocket science to install a car seat. And I've heard that number for years, that people don't do it right. So what's going on?
Well, it's a good question. I think what's going on is that First of all, the automobile manufacturers do include information in their owner's manuals on how to attach at the various attachment points that are present in newer vehicles today. Oftentimes, there's brackets that are between the seats that you can connect them into, and then how to tighten and tighten them up. But the car seat manufacturers don't actually tell you how to install the seat. That information all comes with the seat itself. And like a lot of things in life that we deal with that we're trying to install and put together, sometimes it's not always as clear and helpful as you'd like it to be. So I think it varies by car seat manufacturer. There is a national association, I think, associated with car seat safety for children. We're probably a member of that. And they're just complicated to install. I wish I could make it simpler than it is, but it isn't.
Given the stats, though, and the fact that there's a law that says you have to have a car seat, I mean, all the way up to, a small 13-year-old, booster seats and such, you would think they would just, if they're going to be to that extreme, they should take it to the next step and somehow require them to something. Because to have car seats that are only 20% of the time installed correctly and therefore going to save a life, what the heck? Why have the law to begin with?
Right. To me, there are three components. There's the vehicle, and everyone's vehicle is significantly different. Then you have the car seat styles themselves are completely different. And then you have the age appropriateness of each seat. And I think that's probably one of the biggest pieces would be
Right.
my guess, is where mistakes are being made. What is the weight of the child? Not the age of the child, the weight of the child, and what is the appropriate seat. And sometimes they are not easy to attach. They aren't. To get them in the right position and get them tight enough, it's a challenge. It is.
Yeah. And I don't think there's a real easy solution to everything you just identified. I know the support is appreciated.
And we appreciate what you do at the health department. So 796 individuals and/or vehicles were, viewed, and conversations took place to secure that. And I do realize that there is a local business who also promotes it very highly as well. The Toy House is awesome about providing that service. Not only do they provide the product, but I have purchased car seats from them, and as a grandma, and they went out and put it in for me, and I watched her struggle. It is. So it is a service that is needed to ensure safety. Commissioner Rice?
Is the traffic safety program that we have, which is hanging by its fingernails, are they involved in trying to educate in regards to car seat safety?
Well, I think that the program itself relies on the health department to provide what you're describing through the funding that we've received year after year from the Safety Commission. So they're providing $10,000 per year to the health department through their grant-making opportunity, if you will, and we use $10,000 of that to help fund this program at the health department.
Okay, so the fact that they utilize funds, but they leverage funds to, in essence, assist what you're trying to accomplish.
Yeah, it helps partially fund it.
Okay, thank you.
We've done a lot of work with public health and healthcare integration over the past year as well. Just a few examples here of the efforts to integrate with the Jackson Health Network. The slide that you see here is just showing the front page of the burden of mental illness among adults in Jackson County that was completed back in March of 2014. It included recommendations and next steps, and a number of those things have been responded to at this point in time as well. So one of the things it led to was a survey of primary care providers about how they're managing behavioral health care in their practices, because the report suggested that, there are probably a dozen or more individual diagnosis codes for mental health conditions, if you will, and we were curious as to how many of those conditions were they actually seeing in their practices, and how were they managing them. So that was a follow-up survey that was done in also earlier this year in March 2015, actually, but I put it in here because the work started back in 2014 as well. So we're learning more and more about the system and what's working in the system and what's not working in the system of healthcare, as well as behavioral health in the community through our efforts with across the board. We also have a cross-organizational team that's in place between the health department, the health system, the electronic health record folks in the community, and JHN as well. And my intention is for not for you to try to read this particular algorithm here that I have up on the screen. It's more an example of what we found we needed to do to really integrate well our efforts for screening children for lead in the community. What we initially thought was a relatively easy and simple process turned out not to be the case, because what we learned from this as a result of working with Jackson Health Network staff in particular was, okay, we have to go back to the drawing board and really define the steps of this process, who's doing the testing, and how we're interfacing with each other. So that's what the algorithm was all about. So not only did the algorithm get completed, we also updated and completed a protocol, and now we're moving forward with the healthcare system and healthcare providers to really try to fully integrate that program. One of the other things that we worked on in the Health Services Access Coalition, this is kind of a visual, if you will, of how we intend to work together to address the need for cross-organizational discussions about health service access in the community. So I've kind of identified some bullet points there that are associated with this, and the placeholders in the corners of the boxes there are just placeholders at this point, and this will probably get updated. But basically, it's to identify when there is a health services access need in the community, to discuss it, to plan and make recommendations, and you'll notice that the patient is at the center of this whole process. Moving on to environmental health, wanted to share with you some information concerning the number of sewage disposal permits that were issued in 2014, really. You'll notice that there has been a bit of a blip upward. We're pleased to see that. It means there's a little bit more development going on in the community, which we're all hoping that will take off and continue to grow over time. The number of water well permits was issued 214, but that wasn't significantly different from 2012 and 2013, which suggests, I suppose, that some of the disposal permits might have been related to repairs versus all being new, if you will. We also saw quite a bit more increase in activity in the number of soil erosion permits that were issued. 92 were issued in 2014, which is really a pretty significant jump from 2012 and 2013. So we're optimistic about some of the growth that may be occurring in the community.
Richard, could you give us an example of why someone would need to access a soil erosion permit?
I have the expert with me.
Well, the rules state that if you are disturbing a plot of land 1 acre or larger within 500 feet of a stream or water body, I figured I had a big enough mouth. At any rate, the soil erosion permits are all about disturbing land, putting in control measures to keep the soil on the land. It is an indicator of construction projects. If you are within 500 feet of a water body, stream, county drain, lake, regulated wetland, you do have to apply for the permit, and that's through our offices.
I heard you to say 1 acre or larger?
Generally speaking, yeah, unless, you are a riparian, and you are actually, say, on a lake, you have a lake lot, then that doesn't come into play. You just need a soil erosion permit to keep your disturbance of your property from getting into the lake or the river.
Are there occasions in which someone applies for the permit and they're denied?
There are occasions where we find people who should have permits and have not taken them out. We do have that situation. We don't deny permits. The permit is there to get them to put the adequate control measures into place. That's the whole purpose. We're not denying a construction permit or anything along those lines. Does that make sense?
It does. So if information comes to you that an individual should have requested a permit and they did not, are there legal repercussions?
There can be. We can put a let's do a scenario. Information comes to us that a landowner has started construction on a project of their home or whatever, and they were issued the building permit without a soil erosion permit, but they should have had one because they're adjacent to a wetland, river, lake, what have you. We will go down and inspect. We can put a stop and cease and desist order onto that construction project until they actually get the permit in place and the measures in place.
Thank you.
Thanks, Don. Under personal and preventive health services, 5,965 is the number of immunizations we gave in 2014. Now, that is a continued decrease from 12 and 13. And what we continue to see in the community is that there are other providers emerging who can provide vaccinations to the public. It includes places like MedExpress, but it also includes many of the big box store pharmacies as well, who are able to provide vaccinations as well. So that's not a problem from our perspective. The more providers there are, the more access, the more capacity there is. But what we do want to have happen is get everybody who is giving vaccinations in the community to come together to do community-wide planning to address where we have levels of vaccination we would really like to improve. Influenza is just one of them, and they can tend to be specific by age group. But that's part of the reason what we're doing with the Immunization Action Coalition is to have them join us and work together collaboratively to find ways of increasing vaccination rates.
Well, with that information, is there one centralized location in which all of the separate entities report to as to who was vaccinated?
Yes, there is a centralized Michigan Care Information Registry, we refer to it as MICR, that all vaccinations can be entered into. Now, under state law, you only have to enter the data into it for, I think, children 18 and under. You're not required to enter the information into it for adults, but we're encouraging everybody to do that. There's no problem with doing that. So that's part of the reason we want to bring people together to talk more about, developing the capacity, if you will, to actually enter all the data in that registry, because then it will be available to us on a community-wide basis.
So I hear you to say if an adult has a flu shot, it is up to them whether they have their name reported as someone who was immunized or not.
Yes, there is some patient consent associated with it, and it's also voluntary on the part of the vaccinator, if you will, to put it in the system as well.
Thank you.
Yep. We had 533 sexually transmitted infections, infection rate per 100,000, if you will, which is actually an increase over 12-13. This is the kind of the highest incident rate that we have for communicable disease in the community. We continue to have a lot of problems with the rate of infection, if you will. Most of this is chlamydia, which is a bacterial-borne disease that is easily transmitted from person to person. So we still have much to do here. Everything that we can do, we're doing with the available resources, but I wanted to just share with you that this is one of the focus areas that we have within the health department, and it's one of the primary reasons, at least, that we do have an STD clinic at the health department. One of the other things I think that really kind of jumped out at me from the report is that we had 20 new HIV positive cases occur in 2014. That's quite unusual for us. You can see in 2012 we had 0, in 13 we had 12, and in 2014 we had 20. This is occurring mostly males with males. Some of it's heterosexual. We did have one recalcitrant case here in Jackson County who infected multiple people. The biggest problem that we've run into in helping to control the rate of new infections really has to do with people who are exposed and actually become positive as a result of exposure, not being willing to work with us and local law enforcement to file a statement to that effect. Without the statement, we can't prosecute. And that's just very unfortunate, but that is the current way things are. In the particular case of the one recalcitrant case that infected multiple people, we're at least pleased that the person is off the street because they've been incarcerated for the next 2 years. Not for this. Okay, under health education, health promotion, 18% of 10,000 children that we screened for vision were referred for follow-up, which is a 1% increase from school year 12-13. That isn't a huge increase, and maybe what I'm more trying to convey is, the number of children that we vision screen on an annual basis. These numbers are huge. 38% of children that were referred for follow-up were seen by a physician, and that's up 5% from school year 12-13. And, that, as far as a referral rate, that's pretty high referral rate. It has been lower than that in previous years, but I think we have a very well-trained and educated staff and skilled staff that is able to identify really small differences in a child's vision screening, if you will, in their vision. It's really important because if kids can't see, they can't learn. And this is really much connected to education as well. So it's kind of our contribution, if you will, to trying to make sure children are able to physically see so they can learn. On the hearing screening side, we screened 7,593 children, and about 3.2% of them were referred for follow-up, which is about a 0.6% increase. And 52% of children referred for follow-up were seen by a physician. That's significant. We're really pleased to see that parents are following through and getting their children screened.
Richard, on those screenings, both the vision and the hearing that's performed by the health department, are they performed at the health department or are they performed in schools?
All in the schools.
All in schools.
This is all very carefully coordinated and scheduled with the schools. Yep. In the WIC clinic, our clinic-based caseload was often exceeded in 2014. We had peak enrollment in that year of 5,580, which is up 15% from 2013. So we're continuing to see some of the effects of the economic recession in the community, and we will probably see this begin to slowly drop over time as the economy improves in the state and the county, because more people will be able to access what they need without necessarily coming through the WIC program.
And there is no time limit, limitation of time period in which WIC can be, short of your children becoming of age, or
Right.
it's not a limited frame.
Well, for women, pregnant women are eligible and enrolled in the program for up to a year, and the infant can be enrolled in the program up to age 5, and then they transition off.
But if they were to have another child, then they could be eligible
Yes.
again, and they're not limited in
Right.
that sense.
Right.
Thank you.
Project Fresh is a program that is funded with coupons, if you will, through Michigan Department of Agriculture and the USDA. And the percent coupon redemption rate is 2% higher for us than it was for the state, so we thought that was a nice result. 67% is pretty good. We'd really like to get it higher than that, but that's what it was in 14. Something specific more to the counties, we do kind of track things that are chronic disease related as well, and one of the things that we were able to get access to on the information side was that there's a number of health risk appraisals that are provided to county employees. There were 214 in 2014, and this is a 45% increase from 2013. So we're pleased to see that, because it means more people are getting coaching and mentoring to help them deal with the health risk behaviors that may be part of their lives. 2,360 is the number of employees participating in behavior change opportunities. This is all coordinated through the HR department, and we have staff who sit on the wellness team, and that's an 85% increase from 2013. So we think we're making good progress. No presentation from the health department would probably be complete without talking about teen pregnancy. The teen pregnancy rate was 162 per thousand in 2014, but this is a decrease in the rate since 1990 that's a 162% decrease in the rate since 1990. It's not actual case numbers, it's the rate decrease. And you'll see it on the next slide that it's really dramatic looking when you look at it visually. But that's also, we're looking at a 23% drop from 2012 to 2013. So we're continuing to move in the direction that we want to. Teens in the city are 4 times more at risk to become pregnant than teens in the county overall. We have the ability to pull those numbers and statistics specifically, And we continue to do a lot of work within the city of Jackson with the teens that live within the city boundaries. And also, teens in the city are nearly 3 times as likely to repeat a pregnancy as they are in the county. So when you talk about health disparities and really trying to focus your resources where they need to go the most, that's where we're working on teen pregnancy. And this slide here is showing how we're doing. You can see that our rate was somewhere just south of 120 per thousand in 1990, and it is now down to roughly almost 40. That's a huge change. Now, when you look at the next slide here on teen pregnancy birth rates and repeat teen births, this is again just kind of showing you visually what I just talked about in 2 slides previous, that the teen pregnancy rate in the city of Jackson, you can see is almost 3 to 4 times is higher than the state rate and the county rate as well. And the teen birth rate, of course, kind of follows right along with that, and then repeat teen births as well. So we want to continue to work with abstinence and other teen pregnancy prevention initiatives to help drive down the rate. I wanted to make a quick comment, too, about the abstinence program, because I remember hearing from a member of the public here recently about abstinence. I think what's important to point out is that what we know about teen abstinence prevention programs is that they're not particularly effective when youth are teenagers and youth and teens are sexually active. It's not a particularly effective program. Our program here in Jackson County is focused on 11 and 12-year-old people, youth. We're targeting the 6th grade. So we think it's not just one thing that you do in a community to help reduce teen pregnancy, it's multiple things. And so we're very supportive of continuing to do that abstinence work with that age of youth in the community. And then a couple other slides here. Well, maybe I missed one. Or 2. Okay. Emergency preparedness. Just wanted you to know that we did a lot of work in 2014 on Ebola preparedness and planning. This is an integrated algorithm that was developed with Allegiance Health, and we're pleased to have been able to do that. And I think that our relationship with Allegiance Health and my presence there really helps to make sure that the public health aspects of things are really taken into consideration. And also, they've actually integrated me into their hospital incident command system. So when calls go out to leadership and Allegiance Health for a mass fatality, I'll also get notified at the same time. So I think that's a good outcome. And again, our mission is working together to create and promote a healthy community through disease prevention and control, health education, environmental protection, and emergency preparedness. And I'll answer any questions you might have.
Thank you, Richard. And if you saw us chuckling up here, we were noting on your PowerPoint slide where it says, "Do not try to read this in the fine print." So we were all getting a chuckle out of that. Thank you for our concern for our
Cut you some
vision as
slack.
well. Yeah, that's good. Richard, I do have one question in regard to one of the slides on the sexually transmitted infections, those rates increasing over the course of this, comparing the last annual reports.
Right.
Is there a specific age group that has increased more so than others?
Well, the primary age group where we see the vast majority of chlamydia infections is 18 to about 25.
Okay.
And that is a very sexually active age group. We continue to work a lot with our healthcare providers in the community. We think that we need to be doing more in the area of reproductive health education through the primary care setting, and we don't think we're doing enough. And we think that's a missing piece. We've had conversations with the Jackson Health Network about developing more quality measures that are specifically related to that. But again, it's a long-term kind of an approach because their plate is very full too.
Sure. Commissioners, what other comments or questions might you have for Richard? Commissioner Mahoney.
How you doing, Richard?
Hey.
First, I just want to say thank you for addressing the abstinence program situation. So I've gotten a lot of questions about that as well. I do have a question, though. What's the difference, or like what things do you do different between working with non-sexually active teenagers or youth and the ones who are sexually active? Is that, does the abstinence program address or help both or just the 11 to 12-year-olds?
Well, the abstinence program is really focused on 11 to 12-year-olds in the sixth grade range, if you will. Right there is where we're focusing on working with those. Now, the program itself is kind of called the Teen Outreach Program, but these are actually preteens. And what we do with them is a lot of mentoring, a lot of coaching, a lot of self-image building skills, community service learning. It's all about creating in them the sense that they're worthwhile people, worthwhile persons, and that sex can wait, basically, is the message. And so we continue to work with them very much in that venue. On the other older ages, if you will, we oftentimes will see parents coming into the health department bringing their young teen daughter or son in to sit down and talk with us about preventing teen pregnancy or just having questions and concerns about reproductive health and sexual activity in general. So it takes place in both age groups. And then, of course, we also are seeing the teens who come in that we probably hadn't been successful reaching in the community who are actually infected and have been identified and tested through the healthcare system. They'll get reported to us. They can come to us for contact tracing and help with their partners and notification. So we're touching as many as we can across the board in the different age groups.
Right. And then I was also curious if it would be possible to request from you some more detailed information about the STD statistics and the HIV statistics in the county, specifically like where you're seeing the most at, like whether it's in the city or what area of the county.
Yep,
Which
I
you
can do
just
that.
shoot that to my email.
Sure.
Or something. And then what measures are we taking at the health department to educate the community about the increase in the HIV and the chlamydia and stuff like that? Like, what measures do you guys take to educate the rest of the community that this is actually happening?
Well, we work a lot with HARC, which is the HIV and AIDS Resource Center. They're based out of Ann Arbor, but they have an office here in Jackson as well. So we work with them, and we work with other organizations in the community that are specifically interacting with, in one way or another, the people of most concern for us. We have pretty good working relationships with Jackson College Health Services, with Baker College as well. I think there's more that we need to do. This most recent increase isn't something that we have, at this point in time, really put a lot of publicity into in any way in terms of informing, but we need to do more with it. So I appreciate you bringing that up.
Yeah, there's some inaccurate information. I had a lot of people discussing like the increase in the rate. I think, probably word got out there was an increase in the HIV, but information can get misconstrued, and people were saying, 75% of people in Jackson have HIV. I'm like, I don't think that's accurate at all.
Not at all.
But that is a rumor that was floating around per social media for a while. So that's just interesting to see that there was actually an increase. I think that was all the questions I have. Thank you.
You're
Richard,
welcome.
to follow up on Commissioner Mahoney's comment, though, prison data is not included in this. Is
That's
that correct?
That's correct.
Commissioner Rice?
Also, would it fair to say that if we have a reported increase, that potentially we have an increase in unreported or unknown? Okay, thank you.
What other comments or questions might you have for Richard?
This is mostly just for clarification. I think I'm pretty sure what it means, but the recalcitrant, is that someone who's infected and they know that they're infected,
They
but
know they're
not
infected,
informing
they've been
partners?
counseled, we've actually issued health threats to others orders to them, and they continue to infect other people. The biggest barrier that we have to effectively enforcing the communicable disease rules against a person who is knowingly infecting other people and not telling them about their status is through court. We can take people to court, if you will, through the prosecuting attorney's office and have them, it could be a combination of fine or a short amount of jail term. It isn't the kind of penalty I would like to see. I think the maximum potential incarceration is only 2 years. But the biggest issue is getting people who've been infected by another person to actually come forward and be willing to sign a statement to that effect with law enforcement. That's our barrier.
Thank you.
Yeah.
Great conversations, thank you. All right.
Thank you.
Next on the agenda, we have a resolution in front of us that is to go to the full board. It's Resolution 11-15.39, which would allow the Human Services Board to allocate $800,000 of the MOE fund for payment to complete the flat roof on the Jackson County Medical Care Facility. The documentation is in front of you. We understand that the total cost of the roof repair will be between $1 and $1.5 million. And again, they're requesting the allocation of $800,000. It's my understanding it was discussed at study session last week. What questions or comments might you have about this resolution? Commissioner Mahoney?
Just curious for some clarification on where the difference is going to come from.
That is their intent to use funds that they are setting aside currently and have been setting aside for operational capital expenses. Mr. Brown, would you like to address this?
You're correct. It's coming out of the funded depreciation account. And as of their meeting on the 29th of October, half of their funded depreciation amount is going directly to it, so $10,000 a month going forward, just to make that difference. But they've also have built up a funded depreciation.
Any other clarification or comments regarding this issue? Great question, though, Daniel. It's important that they are vested in this as well and have been setting the funds aside and will continue to do so as this project moves forward. If there are no other comments or questions, I'd be looking for a motion to move this to the full board. We have a motion and support in favor of this resolution. All in favor say aye. Opposed, the same. This will move on to the full board. Thank you. Next on the agenda, we have Fair Housing Resolution. We have Resolution 11-15.38. The county is required to approve this resolution in support of the federal fair housing regulation to continue to be eligible for community development block grant funding. The resolution is in front of you. What comments or questions might you have regarding this resolution? We have motion and support to move this resolution to the full board. All in favor say aye. Opposed? This resolution will be moved to the full board. In front of you, board members, were the claims from October 2015. Any comments or questions regarding those claims? If not, looking for a motion to move them forward. I'm sorry, did I misspeak, Adam? Because I said move it we just take care of it here. It doesn't need to go to the full board. I misspoke, didn't I?
No, this is a you're talking about the claims?
The claims, right. We take care of it here.
That's right.
Yes, okay. So we have a motion and support to pay the claims. All in favor say aye. Opposed? We have other meeting minutes. And there are none. We have our December reporting schedule, including DHHS, MCF, Veterans Affairs, Department on Aging, Health Department, and Lifeways that will all report to us in December. That leads us to public comment. Is there anyone that would like to address the Human Services Committee? Seeing none, are there any committee member comments? Seeing none, we'll adjourn to the call of the chair.